Dr. Price is recognized.
Thank you, Mr. Chairman. There's so much misinformation in the last 5 minutes, I don't know quite where to start, but maybe I'll start by saying that the SGR, which all of us agree is a disaster in terms of its compensation of physician reimbursements for physician services for seniors, everybody understands that the IPAB has been called the SGR on steroids. So if you like the SGR, you'll love the IPAB. Our whole goal here is the highest quality of care. We disagree drastically about how to get to that highest quality of care. Our side believes that patients and families and doctors ought to be making medical decisions. The other side believes that Washington ought to be influencing those medical decisions in very intimate ways, which is why I think it's important to point out, Mr. Chairman, that a list of medical entities, physician entities, folks taking care of patients, nearly 500 of them supporting repeal of the Independent Payment Advisory Board. So it's important to remember that we're talking about patients, and the people that are taking care of the patients are saying this will be a disaster, a disaster. We've heard a couple things from our friends on the other side who say, oh, don't worry about it, it's 2020, 2021, not going to happen. I draw their attention to Appendix A in their packet, the first date where something regarding IPAB must occur by law, April 30th, 2013. 2013. That's when the chief actuary has to begin to state whether or not these costs are going at rates that are unacceptable, not according to patients, not according to any market at all, but according to Washington. We've heard that the words tossed around like voluntary and advisory as it relates to IPAB. There's nothing voluntary or advisory about the Independent Payment Advisory Board. It's a denial of care board, and its sole purpose is not quality of care, as my colleague just talked about. Its sole charge is to, quote, recommend cuts in areas of excess cost growth. Decrease costs, excess cost growth, then you got to look at why the cost of health care is rising. And it's rising higher than the gross domestic product. Why? For two main reasons. We heard this last week from the chief actuary for CMS as well as the OMB director. The 2.5% is due to, quote, utilization and innovation. Utilization and innovation. So if you're going to decrease the cost, what do you have to do? You have to decrease innovation, that's quality of care, and utilization, that's access to care. Which brings me to my questions to first Dr. Penson. There's some notion that if you decrease payment to physicians, that doesn't decrease the access to care for patients. Can you help us understand that mechanism a little bit?
Well, it's going to affect, you decrease reimbursement to physicians, it's going to affect things in two ways. First is the example I've thrown out there already, which is at a certain point, physicians are going to close their doors and turn off the lights simply because they can't make ends meet. And so for many physicians, they'll just opt out of Medicare, and we've already seen this in Medicaid. The other thing that physicians will do is if they get paid, if the reimbursement gets paid less, if they try to keep their doors open, keep things open for Medicare, they'll just try to see more patients. Now, you say, okay, well, that's good. We want our doctors to see as many patients as possible. But Ms. Neese will back me up on this. There's a big difference between when you get, and you know this as a physician, you get a good long visit with your doc where you get to talk to him or her, or you're sort of in and out really quickly, because that's what he or she has to do just to keep the office open.
Dr. Gottlieb, I want to talk about some real-world consequences for the physicians out there trying to care for their patients in spite of the rules that we toss upon them. My understanding is that if a physician is continuing to try to see Medicare patients, and if a payment for a service in Medicare is not of a rate that would allow the physician to continue to keep his or her doors open, that physician can't see that Medicare patient and provide that service if they agree upon another price that the patient would want to pay to that physician to see him or her. Is that right?
Oh, that's right. Under the law, you can't balance bill the patient. You have to accept the customary rate under Medicare if you opt into the Medicare program. I think the other caveat here, and what I'm seeing in my clinical practice, I practice hospital-based medicine, but I'll refer the patients to primary care providers as a discharge from the hospital. And what I see more and more is just physicians capping how many Medicare patients they'll allow into their practice, and they'll say I'm closed to new Medicare patients. We've seen this in Medicaid for years now. It's very hard to get specialty care for Medicaid patients that I'm discharging from the hospital. quite unfortunate.
And therefore, huge decrease in access to care. In fact, last week when the Secretary was here, she said 98.4% of physicians see Medicare patients. I asked her specifically how many physicians are decreasing the number of Medicare patients that they're seeing, and the Secretary could not answer that. And it's a huge, huge number. Access to care is being compromised. IPAB damages access to care, and it's time to repeal it. Thank you, Mr. Chairman.